All right. Hello, everybody. My name is Stephanie Skopik. I'm a nurse practitioner with Mission United from CMHA Durham, and I am very pleased to present for you today about the Mission United project and how we provide a bridge to healthcare services and social services as well. I will focus on the healthcare component, and then Erin will speak with you a little bit more about the social services work that's being done on site and the intersect between the two. So here's our clinic when we first arrived to site. We had 2 exam beds and a few boxes of supplies, and we were seeing about a trickling of individuals, about maybe 10 people per day. A brief client profile. I think it's useful to have an understanding of, the individuals, the overview of individuals that were and continue to come to Mission United. About 15% of clients that we see had an existing medical chart. So they were unknown to our team, despite the fact that we had been involved with vulnerable individuals and vulnerably housed individuals for several years prior to attending at this particular site. About 70% male, about 30% female. Note certainly that approximately 1/4 of individuals accessing GTA shelters actually identify as 2S LGBTQ. And so certainly that was something that we took into account as we were developing our healthcare service for this group of individuals. The age category breakdown you can see there, and so quite a more of an aging population, but in the context of reduced life expectancy, given the number of conditions and health challenges that folks face when they are vulnerably housed and or homeless. Most of the individuals we see are chronically homeless, which means 6 months or more. And about 30% have a diagnosis of serious persistent mental illness, which is typically schizophrenia, bipolar disorder. About 65% of the individuals we see have what's called a concurrent disorder, which is both a psychiatric diagnosis as well as an addictions concern. More than half don't have access to a health card when they come to us, and nearly all exist in this constantly stressed sort of frame of mind in the context of pervasive life trauma, recurrent trauma, system facilitated or system induced trauma. And many individuals come with limited insight and or poor executive functioning, which really means that the way they function in their day-to-day life is much less than what you and I are able to accomplish in our day-to-day life. The way that we perceive the world, engage in the world, move through the world is quite different from the way that these individuals tend to make their way through. So a quick clinical summary, you can see about 30% of individuals are coming to us for wound care and or pain management. We see a small percentage of folks with where the chronic condition is the reason for the visit. And so that mostly refers to COPD and diabetes and those types of conditions that require ongoing monitoring. But I do find that many times that is not the priority of the individual who's coming to the clinic. It is certainly something that we need to help them manage so that they can move on to the area that is of greatest concern or of highest priority to them. We do definitely facilitate access to medication. So for folks who may have had a provider at one point and or, are on medications long term, when the pandemic hit, it seemed that access to those medications and to any previous provider that they may have engaged with really dropped off. And so we have individuals coming for that purpose, and about 1/4 of individuals we see on a daily basis are coming in for mental health and addiction support. 10% or so are seeking a regular provider, and they know that, initially they come in saying, I need a family doctor or a nurse practitioner. I have a list of concerns or things that I'd like to address, and I'd like to do that here. And then about 16% are coming in for episodic or other concerns. So that may be forms, a sore ear, that kind of thing. And only 2%, interestingly, the visits that we see have been related to COVID-19. And so we do actually do pre-screening on site for COVID-19. We do offer COVID vaccination. We do offer COVID swab, and we do work closely with the isolation center for the Durham region to allow for isolation admissions for individuals who are waiting on a swab result. And so that is a small component of what we do as well. So let's dive into the logistics and principles, because I know that's the area that is of most interest to the group. So I will make a series of recommendations and sort of break those down a little bit in terms of the things that were more top of mind for our team as we undertook this work. So the first recommendation is really to be informed and investigate the needs of the service recipient. And so by that, I have to speak about the social determinants of health. With every piece that we've put together, with every requirement that we've put in place at Mission United, we really wanted to look at the social determinants of health and our ensuring that there was low barrier access to the site. And so we looked at the consent forms, what the applications looked like. We looked at the ways that we facilitate system navigation. We looked at, the physical environment for those individuals who are living rough and or intense, really acknowledging the need for safety, acknowledging and working with the degree or the level of exhaustion that people are coming with. Certainly looking at housing and housing first as a priority determinant of health, and ways to implement social support and leverage social support networks for these individuals. So, certainly not forgetting about the street family and the individuals that they spent years sort of collaborating with and counting on, if you will. And pets are certainly part of that support network as well for many of our individuals. So I like to highlight that. This little pup here was actually rehomed as one of our clients was housed from the street, and the apartment building wouldn't allow for pets. So that was something that our team was able to support. And this pup was adopted, and regular updates were provided to the client about his puppy, and he was able to be confident that she was safe and well looked after, and settling in, and he was able to focus on getting comfortable in his new home as well. In terms of additional recommendations, really important to map the trajectory in the context of the service recipient's capacity. So what does that mean? It really means looking at service design and being intentional about providing the service in a way that the individual can receive it. And so here I like to highlight the following: the salary model, certainly, where the job is the job. There's no time spent. There's no requirement for being concerned about how people are getting paid, and breaking the care down into, this piecemeal sort of way of doing things. Everybody who comes to the site receives a salary for the time that they spend, and the Oshawa Inner City Health Collaboration has come together and sort of put forward some consistent ways of approaching our work, and committing to leveraging the priorities in a way that makes sense for this group. We look at our policies certainly in terms of service design, and again, just ensuring that everything is low barrier, that the policies that we put in place make sense for the group based on the information that I've shared with you already. As well, we look at the training skills and partnership. And so in our case, we know that the clinical composition really needed to be something that was well thought out. So, we've undertaken to work with nurse practitioners, some physicians as well. We have registered nurses. We have some admin support. We work extensively with outreach staff who go out into the community, and we're able to leverage the technology that we have access to expand or extend the reach of our team. We look as well at cultural competence. So, things like what we wear, what we say, how we speak, the way that we relate to and understand the challenges of our population. And so all of those things need to be top of mind as you're engaging your team and identifying who your partners are. And certainly in our case, for example, we work closely with Home and Community Care Division to address the wound care component. So we actually have a registered nurse who comes to site a couple days a week and focuses on wound care management. We use an app in collaboration with Home and Community Care Division to access wound care experts who can look at pictures of the wounds that we're seeing and help us determine the best way to treat those wounds. And then as well, certainly emergency procedures are something that we need to be prepared to engage in. And certainly we do engage in those on a frequent basis. So we have an emergency response team who responds to any codes that are called in and around the mission. And that consists of a nurse practitioner, registered nurse, a security team member, as well as the coordinator on site. And so we often will run resuscitations and conduct emergency procedures, first aid in those types of situations prior to EMS services arriving to scene. I do like to highlight the harm reduction component because it is integral to this work. So some of the takeaways that I would advise for the group to really know your person and their context. We need to be meeting people where they are. We need to assist individuals and advocate for a system that allows for clear treatment goals and clear treatment goals that are actually accessible. And by that, I mean, not just from a systems perspective, but also accessible to the individual, given their capacity, given their skill set, given their readiness, et cetera. All of those things need to be reflected in the care plan. We do talk with individuals about safer use, test dosing. We do provide health education that is tailored to topics like preventing and responding to overdose. We do hand out safe use equipment at the mission, and we certainly make available withdrawal management therapy, methadone, Suboxone, and Sublocade as well. All right. I do like to highlight the 3 pillars for harm reduction because these are concepts that apply not only to substance use, but to all areas of potential harm. And so looking at the demand reduction, the supply reduction, and the harm reduction. And so using substances as an example, looking at ways to prevent, delay, reduce the desire to use substances. Well, in our particular case, we leverage access to an addictions physician. We do that with the use of virtual platform most of the time, and it's on demand. So folks can come in at any time of the day during operation hours, and they can leave their sample and they can access medications that will reduce withdrawal symptoms and help them be more comfortable so they can focus on the work of a goal to reduce and or cease the use of a substance. Certainly supply reduction is more of an enforcement-based concept. So sometimes working with DRPS, Durham Region Police Services, to regulate and reduce the supply of substances, for example. You know, we've seen individuals come to the mission not to access services, but rather because they know it's potentially a good place to deal their drugs, deal substances. And so we work with our security team and DRPS services to ensure that those individuals are kind of redirected to access services and focus on their own well-being and or move their business along somewhere else. We do also look at the harm reduction component, which I've spoken about already, but looking to reduce adverse health, social, and economic consequences of substance use. So these are the three pillars that I think should be top of mind when any service is being designed for the homeless or vulnerably housed population, particularly in more of the urban centers where the opioid epidemic has really hit hard. And that's, of course, to avoid situations like this, where resuscitation is required, Narcan is administered, and individuals are then, unfortunately, experiencing severe withdrawal and at risk for a more likely overdose situation in the hours and days ahead. So again, really tailoring the service to the service recipient's needs as a key principle here. So for our team, we knew that access to healthcare had to be in person. It had to be on demand and timely. And we certainly had to provide access to specialists by coordinating with our outreach staff, with our peer support workers, leveraging the virtual care platform, which is a video care platform. And doing that in the context of, no health card or no OHIP coverage for several of our individuals. So that was part of our service design and continues to be so. Another thing to consider is transportation. In our geographic location, we have individuals who consistently move along the 401 corridor. And so we really had to consider how we were going to move individuals from point A to point B, particularly, as one example, since the COVID isolation center for vulnerably housed homeless individuals was located about 25 minutes away from our hub. So that needed to be part of what we considered. And so I would encourage you to dig down and really look at the needs that are required to be part of your plan as well. And then, of course, seek to welcome and respond with an equity lens. So in this particular case, I like to highlight the disability as cognitive and or mental. So we know that, physical disabilities are a little more seen and acknowledged, particularly when we seek to secure income stability. And so when we're applying to ODSP, we really, one of our priorities has been to identify and diagnose and then provide information or details around cognitive and or mental health care concerns. And the impact that those things have had on the individual's life and ability to participate in their day-to-day responsibilities. As well, we acknowledge that about a quarter of individuals accessing the shelter system do identify as being 2S LGBTQ. And so our services do include hormone therapy, surgical referrals, and certainly our policies reflect a respect and an acknowledgement for those individuals as they come to access services. I've mentioned already that folks that we see tend to have a reduced life expectancy. And so palliative care is something that we have also built in to our model of care. So we have providers who have expertise in providing palliative care. And we have providers who have expertise in serving the homeless population, particularly sort of getting creative around shelter partnerships, working with some of the pharmacies, working with home and community care division, so that we can provide the most optimized service for those individuals who are entering their end of life journey. And so certainly something that needs to continue to be a priority and continue to be developed in our region and many other regions in Ontario. But I wanted to put that on your radar as well. So this is our clinic today. So we went from the 2 exam beds to 5 clinical spaces or exam rooms, and seeing about 10 people per day to now about 50 people per day. So things are certainly busier, and we have a team of 3, typically 3 providers for each day. And so, we certainly need to start thinking about matching the resource to the demand that we're seeing. But this is what the clinic looks like currently. And the feedback's been very positive. Individuals, if I can summarize, they feel comfortable, they feel welcomed, not unjudged. They feel that the services are appropriate to their needs, and they feel that that they can come in whatever state they're in. And so, as far as I'm concerned, that means that we have achieved something unique, and we have achieved something that has been meaningful and effective. But I'll let Josh tell you a little bit more about his experience.
My name is Josh. The question was, how do we do things differently than other places that help? This place does everything to save my life. Feeding me to free medical when I didn't have a health card. It's more than it's the people here. I stayed here for 5 months. I think it had a lot to do with the meetings here. It was just anything that helps them get on their feet or to get away from addiction. This place has been it for me. It's the people here, especially just I don't feel alone anymore. It's just a different group of people, a different way of doing things, and it's really helped my life. Thank you.
So in summary, really the takeaways are to be informed, investigate the needs of your service recipient, map the trajectory in the context of their capacity, which means provide the service in a way that folks can receive it based on the way that they're functioning in their lives today. Design the service around the service recipient's needs. So, get to know the population, look at the literature, look at the trends, look at the service gaps in the area, look at how people are falling through the cracks, and seek to address those. And certainly seek to welcome and respond with an equity lens, so that all of the individuals who the marginalized within the marginalized, all of the individuals who are struggling and who are experiencing homelessness can feel that they are seen and that the service is for them. Thank you very much for having me present today. I look forward to the question and answer period, and I will see you after Erin's presentation.